Thank you. Such a great introduction, Aiste. Thanks for making this wonderful introduction. And it's my pleasure to be speaking here about urticaria and pregnancy and to talk to our patients, especially. I hope this information will be useful for them and for their relatives and friends. And I hope many people share this knowledge so that many people can benefit from it. So I start by sharing my presentation. So here it comes. And I'm a dermatologist and I have expertise in treating many kind of skin disorders as well as urticaria, which is my favorite disease. So, and we made a nice study that included almost 300 urticaria patients who experienced pregnancy during their chronic urticaria. So I will going to present the results of this study. So thank you, Aiste, for making this nice introduction about that study. First of all, pregnancy is a very precious condition because as females, we have a foreign body in our bodies. So there should be an adjustment in our immune system because if we have the strong immunity, we can see the fetus as a foreign body and we want to get rid of it. But this is a wonderful nature, a magnificent nature that provides us enough immunity, but also a bit toleration that can go with the which can protect us from the infections and also provide tolerance to the fetus. So some changes happen at the beginning of the pregnancy. There is more inflammatory cells that are arranging if there is something wrong with the fetus and if it should be excreted, and then if the body decides that it should stay, then there is an anti-inflammatory environment and the immune system goes a bit quieter. And in the end, when we need to take the fetus out, take the baby out, then we have again increased immunity. So of course, I'm not going into details of the T cells, B cells, but very briefly, I want to tell as such that our patients can understand. So there are immune response changes during the pregnancy. And at the first trimester, at the first and third trimester, there is a predominance of Th1 immunity, which is associated with autoimmune disorders. And at the second trimester, there is the Th2 dominance, which is associated with allergic responses. So what happens is asthma and atopic dermatitis tends to worsen at the second trimester and third trimester, but the autoimmune diseases usually tend to get better during pregnancy, and we have a propensity for infections during pregnancy. So what happens to chronic urticaria? We really didn't know that, even though chronic urticaria is a female dominant disease. We have 70% females in our patient populations, usually. Sometimes it's even more, up to 80%. And females has a higher disease activity and they are suffering more when compared to males. So what happens during pregnancy? Does it get worse? Does it get better? Do they need treatment? How are the birth outcomes? How does lactation affect chronic urticaria? So we wanted to understand and learn about these questions. And then we went to our UCARE network. UCARE network is the Urticaria Centers of Reference and Excellence. And now currently we have almost 180 UCARE centers all around the world. So we asked our colleagues to participate in our project and send us the data of their chronic urticaria patients who experienced pregnancy during their chronic urticaria course. So we delivered a questionnaire to the patients and wanted them to answer the questions on their experience of pregnancy and urticaria. So we included patients who experienced pregnancy at the last 3 years because we didn't want to include recall bias because patients may forget about their experiences if the pregnancy was very old. So we had 288 patients included in our study from 13 countries and 21 centers. And most of the patients were chronic spontaneous urticaria. As we usually see, the most of the chronic urticaria patients is chronic spontaneous urticaria rather than inducible urticarias, and age at pregnancy was 32. And the distribution of severity of urticaria was similar in mild, moderate, severe. So 1/3 had mild, 1/3 had moderate, 1/3 had severe disease. So it was a good distribution. So we had very nice publications out of these studies. The first publication tried to understand the effects of pregnancy on chronic urticaria. So as I mentioned, the design and what happened during pregnancy is, as Aista also mentioned, half of the patients' urticaria tended to get better during pregnancy, but 1/3 had worsening of their urticaria, and 10% of them required emergency visits for their chronic urticaria exacerbations. And these exacerbations tended to occur during the first and third trimester. As I mentioned earlier, Th1 responses increased in the first and third trimester. So this is compatible with the understanding that urticaria is an autoimmune disease that tends to act like other autoimmune diseases. And it showed an overall improvement during pregnancy because the angioedema frequency really decreased from 35% to 17%. So there was also decrease in angioedema frequency, and also, the ones who improved during pregnancy, half of them worsened after delivery. So this really shows that hormones and the immune milieu is acting on the patient's disease, so that when this special condition ends, then the urticaria comes back again. So we also found some risk factors that were associated with the worsening of chronic urticaria during pregnancy. And we found that when urticaria is lighter or milder before pregnancy, it tended to get worse during pregnancy. And inducible urticarias tended to get worse more than chronic spontaneous urticarias. And when it's worsening in the previous pregnancy, then it also may get worsened in the following pregnancy. So it follows a pattern. So in general, urticaria overall disease severity decreased during pregnancy. So this was our first publication. And the second publication mentioned the treatment patterns and outcomes in patients with chronic urticaria. And it was published in the European Journal of Dermatology. And so here, we asked about treatments of the patients, and we asked if they stopped treatment before getting pregnant, and only 14 of them said that they stopped their medication before pregnancy. And the ones who stopped medication, usually with a mean time period of 4.6. And here you see the changes of treatments. The patients were not on treatment. 10%, almost 11% of the patients were not on treatment before pregnancy, and this increased to 40% during pregnancy. So some patients preferred not to take any medication during pregnancy. But overall, 60% of the patients received treatment during pregnancy, and mostly taken treatments were second generation H1 antihistamines, followed by high dose antihistamines and first generation antihistamines, and also omalizumab. These were the four most preferred medications during pregnancy. So, and we also saw that in the previous slide, many patients changed or stopped, especially when they are taking omalizumab, they tended to stop it or go to antihistamines, or when they are taking high dose antihistamines, they tended to switch to lower doses, standard doses of antihistamines. So the mainly half of the patients received treatment during whole pregnancy and followed by third trimester and first trimester. And you see in the first trimester, the treatments taken were cetirizine, loratadine, levocetirizine, fexofenadine, omalizumab, and systemic corticosteroids. So let's come to the outcomes of pregnancy. There were some preterm babies that were born before 37 weeks. It was around 9.7, so briefly 10% of the patients had preterm babies, and there was a newborn medical problems that were not really major problems were seen in 8.7 of the patients. And it was mainly the neonatal intensive care unit requirement that was seen in 4.5 of the patients. And there were two anomalies, one cardiac arrhythmia who received Claritin treatment, and cleflipt that had no treatment during pregnancy and no steroids. And these patients, cardiac arrhythmia patients' mother had preeclampsia. So she had a really problematic pregnancy that has nothing to do with urticaria. And so then we found that birth medical problems, neonatal problems, were associated with preeclampsia and high-risk pregnancy rather than associated with urticaria or treatment of urticaria. And we found that when we inquired about if preterm babies had something different, then we found that a bit slightly that omalizumab use before pregnancy was more frequent in preterm patients. But when we did a factor analysis, multivariate analysis, then this disappeared, the omalizumab, taking omalizumab disappeared, and only emergency referral during pregnancy and twins were found as risk factors for giving a preterm birth. So, yes, as a conclusion, our study showed that the severity of urticaria seems to diminish during pregnancy in half of the patients, and chronic urticaria tend to behave more like autoimmune diseases rather than asthma and atopic dermatitis, which tend to aggravate during the second trimester and during pregnancy. So I will give a brief summary again. Only 14% of the patients stopped their medication before conceiving, approximately before 4.6 months. 60% of the patients received treatment during pregnancy. Most common treatment was second-generation antihistamines, followed by first-generation antihistamines and omalizumab. And most frequent treatments were cetirizine, followed by loratadine and chlorpheniramine. Taking medicines even during the first trimester did not change pregnancy outcomes. And also, there were also other findings. Stopping treatment before conceiving did not seem to affect the course of urticaria during pregnancy. Not taking any treatment during pregnancy did not seem to affect the course of urticaria or increase emergency referrals during pregnancy. However, emergency referrals was the only urticaria-associated risk factor that was associated with preterm birth. So it is important to keep the disease under control. Okay, the patients did not stop their treatment, but if their urticaria is fine, no problem. But if their urticaria requires them to go to emergency, then that can last in preterm birth. So it's important to keep urticaria under control. And newborn problems were not associated with any urticaria-related risk factor, including treatment. So here is the urticaria guideline. Maybe we can just briefly mention the guideline. The urticaria guidelines suggest to start with standard doses of H1 antihistamines and increase the dose up to 4-fold if not responding to standard doses. And if antihistamine resistant, then switch to omalizumab treatment, add on to antihistamines. And if omalizumab is not working, then switch to cyclosporine treatment, which is an immunosuppressive treatment. And the guideline suggests the physicians not to use systemic steroids for long term, but to use only for short intervals. So this is the guideline suggested treatment algorithm, and the guidelines suggest that in pregnant patients, the physicians can use the same treatment algorithm, but of course, it should be risk-benefit assessment, and this should be discussed with the patients, and drugs contraindicated during pregnancy should not be used. So what does it say? Prefer loratadine and cetirizine during pregnancy, and for increased dosages of modern second-generation antihistamines, it cannot really make a suggestion because there is no evidence on the use of high doses of antihistamines during pregnancy. First-generation H1 antihistamines should be avoided. So in our study, we saw that chlorpheniramine was the third most used antihistamines, but the guideline doesn't suggest first-generation antihistamines. And so cyclosporine, thankfully, it's not really required. And in our study, we saw that only 2 patients were receiving cyclosporine, but they also quitted cyclosporine during pregnancy. Omalizumab is category B and can be given considering risks and benefits. So in our study, preterm birth was more frequent in omalizumab users, but when we made the multivariate analysis, we found that these patients indeed had more emergency referrals because they had severe urticaria. They had to use omalizumab treatment. So this makes a lot of sense. It's mainly associated with the high disease activity. And in the end, the outcomes of pregnancy are similar to the normal population. So urticaria patients should not be afraid to be pregnant. Even their urticaria can get better, and they have the same outcomes with other people who do not have urticaria. So I think I should stop here. We should always keep in mind that severe disease activity can be risky for patients who get pregnant during their chronic urticaria course. And we should always discuss with the patients the benefits and risks of the treatments, and should be connecting and talking with our patients about the course of urticaria during pregnancy, which tend to get better during pregnancy. Thank you for your attention, and maybe questions now or later. I stay.